if you have some infrastructure in place to absorb a leakage or that loss of revenue with more volume-based home infusion cases, or you have these ambulatory and surgery center, you can absorb a little bit of that to make sure that the top line stays intact and that, again, you're getting access to the patients who need it the most.
Without supplies, there's no surgery. Without products, there's no patient care. Welcome to Power Supply, the healthcare supply chain podcast focused on helping you navigate the intricacies of logistics, purchasing, contracting, and supplier relationships. Each episode, we speak with healthcare executives, supply chain leaders, and innovative entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the loading dock to strategic sourcing, from buyers to the C-suite, and across the enterprise, we tackle the real-life issues impacting the healthcare supply chain. Whether you're tuning in for conversation or inspiration, we're glad you're here. You're just in time to hear it from the source and stock up on insight. So sit back and plug into Power Supply.
Today on Power Supply, we will speak with Derek Imars, Executive Director, Pharmacy Supply Chain at IU Health, and we're going to be talking about infusion therapy. And he's going to make a convincing argument about why you should treat it as your own service line. There might be some money in it for you, and if you're out there working at a critical access facility, this may be right up your alley. Great conversation today, Hayes. I'm so glad to have Derek back. He's a wealth of knowledge.
We touched on a lot of topics in a lot of ways potentially to make money. So you better stick around and learn.
All right, everybody. We'll be back with Derek Imars. Stay with us. Just a short break, and then we'll be back.
I'm Hayes Walder.
This is Gary Skinner.
And I'm Justin Poulin.
From the studios of Healthcare HQ, you're listening to Power Supply.
All right, everybody, we are pleased to welcome back to the show Derek Imars, Executive Director, Pharmacy Supply Chain at IU Health. And, you know, Derek, you're really our only pharmacy supply chain expert that we've had on the Power Supply podcast for the most part, maybe a couple of others, but we've got to continue to expand and bring, you know, the voice of pharmacy to the show. But we're really psyched to have you back. And this is a cool conversation we're going to have today that kind of emerged from discussions on the Power Supply Advisory Group. And then we had a chance to meet up at the Vizient conference in Vegas. And I think, you know, we dove a little deeper into the discussion. But like today's topic, why you should treat infusion therapy as its own service line. And so, Derek, thanks so much for coming back.
Thank you, Justin and Hayes, and appreciate you both giving a platform and a voice to not only supply chain, but the pharmacy space as well. So it's been nice to join that journey and learn from you.
Well, we're learning more from you, Derek, I promise you. And
no question. Yeah, absolutely.
I appreciate the kind comments, but I promise you we're learning a lot more from you. Derek, just in case nobody caught your first episode, maybe just talk about your journey into healthcare pharmacy.
Definitely. So I started my career with Ascension Health years ago as a staff pharmacist. And during my time there, learned the ropes, learned how operations worked, learned how to build relationships and really coordinate clinical care in that role. And eventually, like most professionals, wanted more, jumped into leadership, became really fascinated with the discrepancies in the pharmacy space in terms of how we manage our supply chain or how we engage with our automation to drive better patient outcomes. And I realized that there was a pretty wide gap between the intended outcomes we wanted and what we were seeing. And some of that had to do with technology. Some of that had to do with the infrastructure that was available to us. And then other pieces, I think, you go through pharmacy school, you're not always trained in classical or traditional supply chain management, especially in the healthcare space. So I took that knowledge base and while I was at Ascension, was able to switch intercompany to an organization called the Resource Group. I spent roughly 4 years there. That is a supply chain organization, and I still supported pharmacy, but it was a great opportunity to learn more about the inner workings of a supply chain domain. And so I affectionately call that period of time my time in the wilderness, learning really what I could bring back to the profession and really trying to take some of what they had established in their space and tie that back to pharmacy to see if we could support care. And so now I do serve as executive director for pharmacy supply chain with IU Health, and I've been able to execute and bring some of those fundamentals along, and it's been a lot of fun, really gratifying. Definitely challenges, but at the end of the day, you can see the progress.
Hey, Derek, kind of an aside of all this is that journey from pharmacy school and being a clinical pharmacist to where you are now. I mean, honestly, you probably didn't learn very little of the supply chain and the executive functions and those type of things in school. And can you kind of put some guardrails on how much it's changed? In other words, in the last, I think 10 years, pharmacy's really evolved.
I would agree, Hayes. What opened my eyes to the opportunity was went back, got my MBA, and fortunately I was in an environment where I was supported by my boss to really take some of those concepts and apply them. But that was years ago at this point. But as you just alluded to, the last 10 years has been wrought with several challenges for the pharmacy profession, but also several opportunities. We've seen pharmacy expand and go through several widespread shortages, not excluding COVID, right, in 2020. So that was a major hurdle. Baxter's had some infrastructure changes that have really brought some pharmacy supply chain challenges to the top of the heap. But to your point, Hayes, there's not a lot of formal education in the pharmacy space, and I think that's something worth advocating for, because at the end of the day, I like to say, hey, we're the only supply chain professional that has to have a license to actually touch the supply that we move. And so having an understanding of the balance sheet, or having an understanding of how to flip product to cash and what that does for the benefit of the company and the long-term financial longevity, that's really important to understand. And so, again, to your point, Hayes, this is something that I've just picked up along the way, and I've tried to implement and bring forward and learn from others. But there's a long way to go in terms of structure.
So, Derek, when we're talking about infusion therapy, I used to do home health nursing. I did inpatient nursing. I did do a lot of home infusions. But when we start talking about treating it as its own service line, are you talking about all encompassing, like both in inpatient settings? Are you talking about home infusion? Like, let's just kind of center the conversation a little bit before we jump in.
Definitely. It's a great segue into the conversation. Home infusion really sits today. We're a specialty pharmacy set 10 to 15 years ago. So for those folks who are not familiar with specialty pharmacy, these are newer agents. They require some care coordination. They require a little bit more specific handling than just going to your neighborhood CVS and picking up an antibiotic or something for pain. And so through a lot of the work that's been done the last 10, 15 years, the specialty pharmacy division has really boomed. And what I like to say is that infusion pharmacy is specialty pharmacy, except instead of taking an oral tablet or injecting yourself, you do have to have a nurse or a provider administer that for you. And so if you look at the infusion landscape today, it's broken out into several different categories. One includes what you mentioned, Justin. You've got home infusion care, but then there's also hospital outpatient department infusion centers, are typically where people think where you would receive chemo or oncology. But what I'm excited to share about today is there's a few other areas that we're looking to optimize and expand and bring forward so that patients have better access.
It's interesting you're talking about, it's specialty because it requires different handling, but you talked about something there, which is chemo, and, just like the exposure risks and the handling risks, literally. Obviously, I think if you're doing that in the home, you have nurses that need to have training. The family members probably have to have some safety training around it. So is it complex logistics, not just unique pharmaceuticals?
Yes, I would agree. I think as infusion becomes more predominant and as our population continues to age and there's more chronic illness, we'll see more of a need for infusion services. But to your point, Justin, there's an array and a wide array of different treatment modalities. And so if you look at the way that our infusion centers are set up today, or our home infusion, or what I'll mention is our ambulatory infusion centers, which is it's a new burgeoning part of the infusion space where maybe we set up shop in a physician's office and we're able to engage you there where you're at in your care. It's a crossroads of taking supply chain complexity and meeting it with the patient and where the payer is willing to afford care. And so across all of those areas of practice, there's a very concentrated effort to make sure that the patient is aligned to the right area of care, but also we want to make sure that we're affording the product to them at the right price to reduce the cost of care.
You were likening it to like dialysis centers. So instead of having to travel, especially in rural communities, 3 hours, to get specialty pharmacy, that this might be a way to bring some of that closer to the home so people aren't in hotels all the time or on the road all the time to access healthcare. Is that a good way to think about your ambulatory infusion centers that you're setting up is similar to dialysis in terms of concept?
Yes, I would say so. Kind of setting the table. I like to use this analogy. If you look at your outpatient hospital infusion centers, the HOPDs is what they're called. That's more like your highest level acuity patients would go to these facilities. It's your really intensive treatment regimens. Lots of chemo. Not to say that chemo can't be sent to the home, but there's a good majority of that there. And also there's a requirement for ancillary services, so maybe imaging or lab. The step down to that would be home infusion, which is obviously done in the home, or these ambulatory infusion centers that you mentioned, Justin. They work a lot like those dialysis centers or even an ambulatory surgery center in that it's an area where you can receive care. There's closer access to your point. And folks that live in rural areas, instead of driving 3 hours to a hospital outpatient infusion department, if they're eligible and if the arrangements can be made, they can stay closer to home, have less logistical costs, less indirect cost in the health system. And a lot of times it makes it easier on their family to get them access to care. And so at the end of the day, having options and making sure that they're tailored to the patient and that we can drive some white glove treatment to get them there. That's the secret to successful therapy.
Hey, Derek, obviously, it seems like, it'd be great to have that in-house, home therapies, someone coming to my house and giving me that therapy. But is that typically done by a 1099 contractor with the health system, or do y'all literally have those employees that are doing that? How do y'all have that structured?
That's a great question. So a lot of times I'd say both ways. We can have employed associates that engage with those patients and go to the home, or we can contract. Some health systems decide, let's go into a joint venture with a certain maybe private equity backed company or someone that has established practice and knows the rules of the road, so to speak. And so those areas are leveraged in home infusion. I would say with the ambulatory infusion centers, one of the really interesting things we're seeing is that there is a portion of productivity that benefits nursing staff. And so if you have, say, a physician's office has a specialty care provided in that office and there's an infusion suite, a lot of times you can station or float nurses from nearby infusion centers or even nearby hospitals in more rural areas where there hasn't been as much penetration of home infusion, and you can drive care through these facilities. And instead of, if a nurse goes to one home and the infusion takes 4 hours, that nurse can set that infusion up inside the physician's office infusion suite, and then she can move to the next patient and so on and so forth. And so there's a little bit of flexibility with that model in terms of engagement, but it's really picking out and looking at the data and saying, what do we need here? What service is absent? And how can we leverage either the resources we have or the ones we have to contract with?
Makes sense. And now, obviously, there's no way for you to probably answer this question, but generally speaking, are we talking an hour per patient, 2 hours? How long does therapy typically last? I have no idea.
Definitely. I think depending on the level of care and the agent, it can be anywhere between typically at least an hour to minimum to get folks checked in, upwards of 4 or 5 hours, depending on how many agents they have to receive. And so If we dial into those more clinically complex patients that receive maybe 4 or 5 oncology treatments, they could be in line that day for 3 drugs back to back. Some can be stacked and give it at the same time, but others have to be staggered, and then they also receive some supportive care. So that's another important call out. When patients come in for chemotherapy, I'll keep using that example. A lot of times they have a bone cancer or they have something impacting their red blood cells, so they need supportive care to help replenish or support that bone structure or provide iron back to the system. And so it's not always just the chemo we're giving for those really complex patients, but it's also the supportive agents that make them feel better and help them with the recovery after the chemo.
Yeah. So, Hayes, imagine, all of those hours with a 2-hour drive on each end, or the cost of having to get a hotel just so you don't have to drive on the back end, and who's driving you. And patient transport isn't necessarily going those kinds of distances. And so I can see, Derek, where you would have started to take a look at this like anybody would with the shifts, to kind of like, we're just seeing rural healthcare getting smaller and smaller. And in some cases, they're getting obviously bought up into larger health systems. But I can see some of the more obvious reasons why this would make sense. But technically speaking, we probably could have done this before. The home health already existed. Physicians' practices in every community already existed. So what got you, taking a deeper dive into this, and what were the market shifts that's finally making this something that's being considered and maybe even, done on a more widespread basis outside of your organization too?
Definitely. Great question, Justin. I think one of the key pieces that I have to acknowledge is the shifts in managed care, the payer contracts. And so there is site of care limitations with certain agents. And there's roughly 150 to 160 pharmaceuticals today that payers will only reimburse once at a hospital outpatient clinic. And then they say, okay, once you've received that dose, we make sure that you're safe. We make sure that your labs came back okay. Every subsequent dose, because this therapy is not technically as intense as chemotherapy or something like that, they want those patients to go to those home infusion services or ambulatory infusion services because the cost of care is actually less. And so we're seeing payers since COVID, really, that there was a turning point there where payers said, you know what, our folks can't get into the hospitals because we're under restriction. How can we meet our patients in the field? And so there were several healthcare institutions and creative bodies that made that work during that period of time. But that caught wind, and the pattern of giving more care in the home or in these ambulatory infusion centers caught on, and payers really picked up on that. So they started to say, okay, let's make adjustments to make the overall cost of care cheaper. Because if you go to a hospital outpatient infusion department, that is the most expensive place to receive care. It's also where most of the reimbursement flows. But what they've said is, you know what, for some of these agents that we know are safer, let's bring them back to these other step down locations. And so that's really preempting the market to adjust and to make sure that we have concessions in place as we move forward. I would say another thing on the horizon recently with the Trump administration, the OPPS ruling is looking at reducing reimbursement to these hospital outpatient centers. And so that would be, on a lot of levels, a difficult blow to our healthcare providers. But if you have some infrastructure in place to absorb a leakage or that loss of revenue with more volume-based home infusion cases, or you have these ambulatory and surgery centers, you can absorb a little bit of that to make sure that the top line stays intact and that, again, you're getting access to the patients who need it the most.
With the site of care moving, sounds like more and more, that probably makes your job a little bit more difficult, and you're on the supply chain side of that, making sure everything's where it needs to be, when it needs to be, and all those things. So all makes it very important.
Well, that's what made me think of dialysis when we were first talking, was like, you're going there and they're really just doing one thing, right? And they got people lined up and the nurses are really focused. And, you've seen this in orthopedic centers too, right? Like if we want to just go to ortho outpatient and ambulatory surgery centers is like, hey, we're really good at, hands and knees, and they like specialize on given days. And so, it allows for efficiency. And when you're talking about the hospital-based scenario, they're doing infusion of all different types. And when you specialize, i.e. specialty pharmacy, maybe in this, more ambulatory based infusion, now you're kind of like probably reaping the benefits of, really just kind of setting up for the same thing. I mean, even being prepared for side effects or, any kind of allergy responses or anything like that. Like, you probably don't have to be ready for 1,000 different things. You kind of have a common profile of what you can expect that day and make sure that you're really well prepared for any adverse effects. Right, Derek?
100%, Justin. I think you hit on a really key topic and key strategy behind all of this. And it's not just buying the drug, making sure that we're producing it in a way that's safe and getting to the patient, but central care and central access is a common theme that's coming forward. And what that means is that clinically and financially, we're trying to navigate that patient and triage them to the appropriate site of care, to your point. And so if we, over time, as health systems become more sophisticated, you'll see that specialization that you see with OR surgeons and certain ambulatory surgery centers or with dialysis. And what we'll be able to do is categorize each patient that comes to our door and say, what prior authorizations do they need? What do we need to do with their payers? Once we've done that work, where do they need to go or where do they want to go? And then we can start to look at our capacity limits as well. We talked about this some previously, Justin, but there are definite capacity limits on our outpatient infusion centers and hospitals, and flow and channel effect really play a part in who can get access to care. And so if we can offload and take some of those patients in a way that makes a lot of sense financially and clinically to a site of care that's outside of the hospital, we make room for those more complex cases. And we're really starting to align the value proposition that we want to see out of healthcare, where we're not spending more for quality care. We're actually spending less and we're increasing access.
So I'd like to see, and this is just from a clinical perspective, there's a big movement to like get away from LPNs. Magnet kind of said you can't be a magnet hospital if you use LPNs a long time ago. And, unfortunately what that did is it kind of forced every sort of nurse other than a CNA to be operating at associate's or a bachelor's level. And we moved away from having different levels of licensure. And I think that's limited our ability to keep up with the demand for nursing. The more schooling that has to be required to be able to operate as a nurse. But you start thinking about these specialty centers, it might actually open up some job markets too, where they say, hey, listen, become a licensed, infusion nurse or something like that, or a technician. And when you take the scope of what that care delivery is and you narrow it down, then you can start to have more affordable degrees. But then all of a sudden we have people to do the work. Because the first thing I'm thinking of is once you get out in that rural community, it's great to move it out of the hospital, but who actually lives out there to be able to deliver the care? Like, you could set it up, but if you don't have jobs, if you don't have workers to do it, then it still fails. And I know I'm going way off the beaten path and, for the conversation, but I think we really haven't solved the clinician shortage situation. And it's because we're not thinking this way. And specialization might allow us to do the things that we need to do to actually create the workers to have quality care delivery, because we just don't have enough bodies on the floors. It's just what it is. And nurses are leaving because of it. So it's making the problem, it's compounding the problem. Let's talk about some of the factors at play. Specifically, you mentioned, I think you already talked about, payers and you mentioned private equity, but private equity's got a big piece in what's going on right now, don't they?
They do. Private equity and then also payer-backed infusion centers and suites are sprouting up. They're all over Indiana. We have a few of each sprinkled in, and we're starting to see those private equity groups really drive down the cost of care and streamline their workflow so that they are appealing. And at the end of the day, I think, they do good work, and it's not a knock on them. But what's happening today is our patients are transitioning over to those private equity backed infusion clinics, and there's a gap in their care outside of our healthcare system. And so we can't see everything end to end like we could if we had infrastructure set up. And so part of the impetus to do this is to make sure that our patients stay in-house. They receive the care from us. We're able to tie that out with them in their community. And then that drives continuity of care and other benefits to them. You make a good point. There's a lot of this competition. And what I've seen in the market is that where providers are more aggregated, you see less of this competition. And in markets where there aren't as many providers, you see more of it. And so they're mostly regionalized, I would say, but you have some national presence as well.
But you don't see many in the rural community, do you?
Not a ton. Not a ton. That's a good point, Hayes. And that's a key piece of our strategy. We have multiple critical access hospitals. So to your point, in those communities, those folks are still driving a certain degree past what we want them to. And so really, treating enhancing our infusion services at critical access facilities, that's as important as opening ambulatory infusion centers or expanding home infusion. It's really a multimodal approach that we want to take to make sure we're meeting the patient where they're at.
That's great because, one thing we were talking about is home care and home therapy, but you can only have so many, nurses driving from, an hour from it's just a logistic issue.
It's not efficient either. More time on the road is less time delivering care. Yeah.
And particularly if you had therapy that takes, 90 minutes to 2 or 3 hours, by the time he or she drives from one to the other, they might only see one, maybe 2 patients a day at best. Yes. And that's just not very efficient, where you could have like your critical access who's got 3 or 4 beds open. That's a great use of that facility.
And one nurse, right? One nurse doing 4 beds.
They might do 10 people, on a day. Yeah. I don't know what the number is, but.
Yeah, it's a great point. And that was actually something that we had talked about, Hayes. You touched that was the first thing that occurred to me too. It was like, we're looking at, critical access and rural healthcare losing dollars, really struggling to find ways, to bring revenue in. And this would be a way for those facilities to kind of have a new revenue stream that might help at least improve their margins to some degree. And it's something for them to be really good at too. And, become, like we talk about it all the time, but, the centers of excellence, right? Well, if critical access became really great at infusion, they could be a centers of excellence for that instead of a jack of all trades, which is what they sort of function like now. So Derek, 2 concepts that you mentioned to me that I think would help make this, operational at a transformative kind of level, which is centralization and, having a command center for the centralization of infusion therapy. What did you mean by that when you and I talked about it?
Yes, definitely. So, and looking at our forward-thinking strategy, one of the key advantages that Indiana University Health has today is a shared service center. We call it the integrated service center. And so we do have a supply chain outfit that provides supplies throughout the state there, but we also have a pharmacy into the building. And really, if you look at our footprint, we're built for scale, we're built for redundancy. And we have the hood space to not only provide non-hazardous drugs, but hazardous drugs. And so we're currently underway, and we've received some capital funding to expand our centralized compounding service center and open up the possibility for us to be the hub to the multiple spokes around the state. So if you imagine, we have specific ambulatory infusion centers that are just within our scope. And again, critical access can take care of themselves, so can the hospitals. But really, home infusion and ambulatory infusion centers, they lack the ability to step outside of immediate compounding. So you make a product, you got an hour to infuse it. If we can coordinate with them, we can do a lot more compounding at our facility that is standardized and produced in a very safe way from one central location, and then distributed through these channels across the state. And so the goal would be, no matter where you're going at in our health system, you're getting the same level of pharmacy quality care and oversight, regardless of if you're going to a hospital outpatient infusion center, which again costs more because there is that pharmacist oversight, or a home infusion footprint, or a clinic. So we're really excited about that. We want to leverage the infrastructure that we've had afforded to us through the organization.
All right, I might be opening Pandora's box with just a few minutes left here. What is CAR T? Because it's something else you brought up to me, and you said, this could be its own podcast, but it ties in a little bit to the conversation, and it's something that's coming. What is CAR T, and how does it fit?
So if you go to any pharmacy conference in the country, you'll hear about gene and cell therapy, and I think there's over 22 of these pharmaceuticals available. But we talk high cost drugs. What's really interesting is that we have within our health system a high cost drug group, and the definition for a high cost drug has changed over the last 5 years because of these medications. And before we would say, hey, an entire regimen that costs $100,000. That's a high cost drug. The Blincyto is in there. There's those pieces. But these agents, I'll get to more of what they do, but they cost anywhere between $1 to upwards of $4 million per patient. And so we're talking lots of risk, right? If payments and all the supply chain components of making sure the payer is incorporated, we've got the supply from the vendor, the AP process, there's all of that risk. But what happens if the patient doesn't get the drug in the right specified amount of timing, or they don't have access to it? And so these drugs and why they're so expensive and why they're so critical to the future of medicine and how we're treating folks is that they're almost curative in what they do. And so these are medications that we can provide to patients with autoimmune diseases, with sickle cell, pediatric cancer, 2, 3, 4-year-olds that receive these agents, and they're able to cure their disease state for the rest of their perceivable life is extraordinary. And so, giving you a little background, these agents actually, we harvest cells from the patient. Those cells are then taken to the manufacturer's lab, mixed with the agent, and then they're reintroduced to the patient. And I am really simplifying this down to a very basic level, but when you provide that drug back to the patient and you've taken all of the extra steps and measures as specified by the therapy, their cells are now equipped and their immune systems are now equipped to fight either transgression against their body through cancer or through sickle cell. And they can live a pretty normal life. And so what is really interesting is that this has mostly been an inpatient procedure, but a lot of institutions are starting to expand into the outpatient arena, which ties us back to, do we have the chair count? Do we have the capacity? How do we make this work with all the demands we have today in an aging population? So that's a little bit of an overview, but it's probably the extent of how far I want to go and how comfortable I am with sharing on it. But it's amazing medicine. It's why we do what we do, I think.
Derek, this has been a big hot topic, the gene therapy piece, with several conversations I've had at our meetings and others, and I'm fascinated by it, but I still don't understand. Can you get prior authorization from a payer to pay for $1 million drug or a $2 million drug? And or if they don't, and you've got this drug that could cure this young child, what ethically, how does all that work?
That's a great question, Hayes. And I think that's one for me that I've thought about a lot. If you scope out, and this is just me thinking through these pieces, I can't imagine having a child, $4 million cures my child's cancer. They can step away from a life of oncology or have their life shortened. I look at, how is society staging this in a way that drives the right outcomes without having, the cost and burden interfere. And so what I mean by that is, imagine a patient goes through payor A, and that payor A has to cover this. To your point, Hayes, with the prior authorization, they have to cover the $4 million pickup. And that patient, 2 years afterwards, maybe their dad switches companies, and now they're with another payer, right? So who should hold the cost there? And so we've seen the government take a step towards saying, okay, we'll fund this. But I think the broader question of, buying outcomes, what we're all trying to do is trying to drive access and drive outcomes. Taking a look at that and understanding how to make it, more feasible for society to subsidize this is going to be something we're going to have to look at as we move forward. Because I can't see there being a break point with the payer saying, you know what, they were under my covered life care policy for 2 years, and then they spent 80 years under someone else's. How do you rectify that? And so I guess
Yeah,
it's
because you might have actually
along
saved the amount of dollars, right? Like somebody
right.
who battles cancer and it's not, 6 months or less to live. And you think about how much goes into their care over 15, well, maybe not 15 years, but through the life of the treatment of their cancer, they might spend the same amount of money or more. And so if you
Right.
can cure something with genetic therapy and avoid all those costs, at the end of the day, if you're just looking at the patient and the cost to treat that illness, it probably makes a ton of sense. But when you're paying a premium for 2 years and you've absorbed the whole lump sum and you haven't gotten the life of the premium payments over the duration of what their treatment would have been, it does really start to create some complexities in how we've built this model. So yeah, what almost makes sense is that there's some government funding on that, and then all the payers pay into it. It's almost like the government insures the insurers.
Agreed. And then to Hayes' point earlier, once the PA is approved, how do you fund it, right? So hospitals are cash strapped. That we're entering a phase where there's less reimbursement. So tie out your idea, Justin. There's got to be solutions on the front end and the back end to float these costs and make sure that we really get these miracle drugs. I'm okay calling them that to the patients who need them.
I'm not going to hold my breath that the payers are going to step up voluntarily
No.
and pay for their. Just my experience with my limited health plan, they don't volunteer anything.
You don't know this, Hayes, but I used to work for a third party payer and an insurance company as a medical review nurse. So I have a little bit of insight into that world too, and we'll stop there. Derek, great.
Training is no, right? We don't pay for that. No. That's your training,
No,
I'm sure.
I mean, I can provide a more balanced view on that, but I can provide both sides of the story for sure. So anyway, Derek, great interview. Bottom line, if they do treat infusion therapy as its own service line and they centralize it, create the command center, set up some of these ambulatory infusion centers, for a hospital, maybe let's go a little bit bigger, maybe 500 bed hospital, where there's a health system that has maybe 4 of those, 2,000 total beds. It's a little bit smaller than where you work today. But what kind of savings does that play from making these kinds of operational improvements?
I'd say, this is, there's definitely savings in terms of the triaging and the white glove treatment. And really, I like to bring this to the forefront too. It's better for our providers. Our providers appreciate having that handoff to a care team that can take care of their patients. But one of the transformative pieces that pharmacy has seen over the last 20 years is moving from a cost center, much like supply chain, right, to a cost center that also drives revenue. And so I see that as the future state. If we're going to continue to experience reductions in hospital outpatient facilities and infusion centers, top line revenue has to continue to grow so that we can keep up with that marginal decrease. There's going to be some contraction in the future. And I think, again, for health systems to financially solve the challenges they need to solve to continue the mission, we'll have to really lean into these services to make sure that not only is access there, but we've also got the business model to sustain all of the storms.
That was Derek Imars, Executive Director, Pharmacy Supply Chain at IU Health, talking about why you should treat infusion therapy as its own service line. And Hayes, there were definitely some potential rabbit holes to go down throughout that conversation. I mean, that's a big topic that we condensed into, probably about 35 minutes of discussion. And I'm super interested in like gene therapy and where we're headed there because, I don't know how we make the shift, but the way that gene therapy is going to treat illness is just a complete paradigm shift. But we're still going to need to access care. And I like their model for these ambulatory infusion centers and just becoming, specialized in that area. And so, if you treat it at its own service line, you can start to specialize. And
you can make some money at it too, which is even better. Obviously, that makes you can get better care. And, he even mentioned a little bit, if you've got private equity starting to come in, there's money to be made somewhere. And so, but you just got to do a better job than they do, or in order to, bring that therapy closest to the patient as possibly can, in some cases into their home. But it's a great topic, and I think IU Health is doing a really good job there, and they're kind of probably ahead of the curve.
Yeah, I think so. We'll have to have him back to dive into CAR T as he gets more and more knowledge around that. And we start to see things unfold there as well. But on behalf of Hayes and myself, thanks for listening to this episode of Power Supply.
Bang!
Thank you for listening to this week's episode of Power Supply. As a reminder, you can help support us by subscribing on your favorite podcast app or by downloading the smartphone app on your iPhone or Android. Simply search for Power Supply in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@powersupplymedia.net. We look forward to hearing from you.